And I'm going to throw with Radka, we're going to throw the session out to questions from the floor. Try and keep your questions short, and then we can get through more questions.
Serge Evrard from Bordeaux. I have a question for you, Karin. You think you have to move to stereotactic, but the philosophy of stereotactic is very different from neoadjuvant treatment because the tumor will be removed by the surgeon, so it's not necessary to get necrosis of the tumor, but you will not cover the border of the surgery which have to be included in a neoadjuvant plan. You understand? And how can you plan stereotactic without making a hole in the duodenum if the tumor is close to the duodenum? So I don't understand the philosophy of the stereotactic in a neoadjuvant treatment, which is to be followed by surgery. So the tumor is removed by the surgeon, but we have to cover a broader field.
I have 3 answers to that. First, you're absolutely right. If you give a high dose to the small bowel, you get a hole or a bleeding. But I think with modern techniques, such as breath hold, MR to delineate, you can avoid that. You should also do imaging during the delivery of your treatment. So not only the upfront planning, but also on the machine itself while you are delivering. R1 resection is still one of the major problems in resectable tumors, and I think posteriorly, because of the organs that are located posteriorly, you can take a somewhat wider margin and you might help the surgeon. And next to all this, there are more and more data that with stereotactic body radiotherapy, first of all, the mechanism of action is completely different compared to conventional, and you might also have this immune response which might be beneficial for the microscopic metastatic disease at a distance. Now, I don't do stereotactic body radiotherapy because I'm scared for the reasons you mentioned, but if you look into the literature, there are several series that show that you can improve resection rate in the borderline resectables.
Thank you.
Hi, Arno Roth, Geneva, Switzerland. I loved your talk about neoadjuvant treatment. I just saw this. You presented this trial, which is like the magic one. It's a magic nab-paclitaxel, if I would call. We know that probably in those preoperative trial, probably it's more the neoadjuvant which count, because in gastric, 50% of the patient never got the adjuvant part. I suppose it's probably the same, it shall be the same in pancreatic cancer, because people don't recover so quickly. So my question is, what is your feeling about that, and why are we persisting doing perioperative treatment, especially investigating perioperative treatment, especially now in pancreatic cancer, knowing what is the truth in gastric cancer?
And you're absolutely right. First of all, this is not very original because that has been done at the perioperative setting. The problem is we're not sure about the efficacy of the treatment as yet. How well do we really address the tumor? We're not sure about the number of cycles to give, and is this enough, or is this too toxic if we prolong it? And in pancreatic cancer, because we have a different situation as compared to gastric, we have a higher proportion of patients where surgery is part of the palliative treatment. And Marcus must not listen now, but I think it is like that. And maybe we're just having a continuum of care, chemo, surgery, and chemo again in a priori metastatic situation and palliative situation, which then still is prolonged. Survival is prolonged by surgery. This might be the reason why perioperative might make sense in pancreatic as compared to gastric.
Thomas, if I can just follow on a little bit on that around the question of ethics. So Gem plus nab-paclitaxel improves survival in the metastatic setting by a few weeks. more toxic. But here you are testing it in the resectable adjuvant setting before you've learnt the results of the adjuvant trial. How is that ethical?
Well, this is clear, and we also make that clear to patients that this is a trial with 2 experimental arms. This is no standard arm, these are 2 experimental arms.
But is it ethical to do that?
Well, our ethics board approved it.
Okay, this is...
And
this is where? Where was this?
This is in Germany.
In Germany, yes. Vielen Dank.
So, and I think yes, because this is, in essence...
no.
This is, I would have assumed your answer, John, but this is in essence, these are 2 single-arm phase 2 trials, and the randomization is required to actually avoid bias in one arm or the other. But this is exactly what, you're pointing out the right thing.
Sure, but the development of science has to be based on proof of principle and proof of concept. And one of the great difficulties we have about radiation treatment is that they are continuing to use the treatment before they've proved the proof of principle, i.e. that it matters. And it doesn't matter because there's no level 1 evidence that radiotherapy should be used in any context in the field of pancreas cancer except for pain relief. And yet it continues. Now, I'm disappointed that medical oncology, you know, should continue to proceed along what, clinical trials, medical oncology have set the standard around the world for clinical trials. And I think it's important that we understand the proof of concept in progressing our understanding of how we treat human beings. So it is a question.
Yeah, but that's exactly what we do. We're trying to get an idea how to move on further, because we will have the APEC data at the time, and we will, of course, amend in case there is no benefit. We will drop the arm. That's no problem. Okay. But this is our 2 phase 1, 2 independent arms that need randomization to avoid bias, but it's not to compare. So 2 experimental arms, but it's absolutely right what you point out.
Am I allowed to comment on what you said?
We'll come back to that because we've got to let these people talk.
Not allowed. Florian Lordig from Germany. I'm a medical oncologist, but I have a question for Werner Hartwig. You mentioned shortly the concept of enucleation of precursor lesions. And for me, it is unclear how you want to evolve this concept, which is clearly experimental. You said that. Do you think it will be possible to identify the precursor lesion nature preoperatively, or is it more that you want to evolve this concept that enucleation is done, and then if malignancy is shown, if it's invasive cancer, then you proceed to radical surgery? I didn't understand how this concept should work out in the future.
Florian, if you think the transition to colon cancer, everybody is happy to perform colonoscopy and cut out the adenomas, the precursor lesions. But in pancreatic cancer, when a surgeon takes out a known precursor lesion, he's always, and there is no cancer in, they always said, why did you operate? The gastroenterologist, okay, they get out everything. So you have to think about getting more information with our problems, with the imaging and all the preoperative things, information you can get. Where are you? You don't know how far the precursor lesion is. You don't know, is it a precursor or is it tumor already? And we know we have a lot of patients with all the Sendai negative patients, they have invasive cancer, 25%, you know, the Heidelberg series. So I know this is a difficult situation, but why don't get ahead and take out the precursors and not wait until the cancer has developed?
Thank you.
John, can I ask a question?
I'm just the chairman.
My name is Markus Büchler from Heidelberg. I would like to congratulate Dr. Haustermann for what you said. John and myself, we have been fighting for 10 years that radiotherapy in the adjuvant setting should be stopped. And you said now it is dead. This is a very important message. And still, you have to speak to America. Here we are in Europe. In America, it's still standard of care, and I'm much disappointed about this. But you said it is stopped, and I think you are on good ground to say that. This is number one. Thank you for that. Travel to America, please.
But actually, it's the same story with rectal cancer. They
Yeah,
continue to give
absolutely.
adjuvant treatment for a very
Absolutely.
long time, while
Yeah.
we in Europe knew that was not the right way.
Agree with you. The second question, or the question I have is, you are now going on the neoadjuvant side to look for the role of radiotherapy. Our own data in Heidelberg are that we have been very much supporting neoadjuvant radiotherapy in pancreatic cancer, but we have become disappointed. It is rather something like 10 to 20% that become resectable. Yes, it is regarding who has a better radiotherapy, other proton, and what you said. Perhaps it is a question of technology. But you know, the Heidelberg radiotherapy, this is good people. They do their best, and we have proton, and we have carbon, and we have all the things. But in pancreatic cancer, we are disappointed. As against FOLFIRINOX, we have a paper accepted in Annals of Surgery where we show that FOLFIRINOX makes more than 50% of the patients resectable that were unresectable. And FOLFIRINOX is much easier than radiotherapy. So I would like to hear your comment on that. I'm sorry to say, but radiotherapy at this moment, I don't see much place in pancreatic cancer.
First of all, Heidelberg has very nice studies ongoing with carbon to look at inoperable cancer mainly. That is the way we should move forward, because you're absolutely right. It is very hard to show that pre-op chemo radiation is superior to pre-op chemo. And we can say, yeah, that's because of all these technology issues. I think that is partly true, because we have at least 2 trials, the Lab 07, where they invested a lot of effort into quality assurance. And even by doing that, they had a lot of major deviations still. And then there is the other one, the RTOG trial, adjuvant setting, I agree. But if you look at outcome in the patients that were treated correctly, according to protocol, then the adjuvant chemoradiation is superior to the adjuvant chemotherapy. So there is still a major issue of quality assurance, and just like surgery, not all centers can simply do this. That's a complex thing. But also in my own experience, we use a lot of FOLFIRINOX in Leuven, and if I look at those patients, usually they tolerate it better than the chemoradiation. So I think we still have a lot of possibilities to improve the pre-op chemoradiation. But if you extrapolate from other studies in other tumor sites in the GI tract, I think the combination should be superior, because you act from 2 different sides. The way radiation causes damage is completely different from the way chemo or other drugs cause damage. I think it's mainly because we still don't know very well how to do it accurately, how to define the margins, and how to develop the technology.
Sorry, you know that we are running SPAC5, and in SPAC5 we are trying to find preoperative radio chemo versus chemo alone, so maybe we get an answer within this circumstance.
But then you should invest a lot on QA, because SPAC5 is a very big network, so I think there are many smaller radiotherapy centers there.
I have also one question. It is more practical question. I would like to ask you, we are speaking about resectable cancer, pancreatic cancer. As a surgeon, would you send a patient who is clearly resectable to upfront chemoradiotherapy?
So thank you very, very much for this question, because I was waiting for this, you know, because I think with pancreatic cancer and neoadjuvant therapy, you have 3 main issues we always like to forget. First of all, if you perform radiochemotherapy or chemotherapy, you need to have a provement of cancer. So you need a biopsy. It's not like colon cancer or gastric cancer where you get access easily. So you do fine needle aspiration. We have 30% wrong negative fine needle aspiration results. You have to continue, you have the bleeding problem, you have the pancreatitis problem, and all the good data is from on-site pathologists, And I don't know how many people here in the audience have an on-site, highly experienced cytopathologist. The second problem you have, they have pancreatic head cancer, they have biliary obstruction. You need to insert a stent. And we know from randomized trials that you increase problems with the, you increase the comorbidity, the problems for surgical results by putting in a stent. And third, what was the third? I just forgot. No, the third is when you look at the randomized trials that are running now, they have all a accrual problem. They don't get patients in. Why that? Because of these two things. And when you look at the results, when you go for the intention to treat analysis, there is no benefit at all. It's just a patient selection, the ones who can complete chemotherapy, you can complete surgery, you get out, and those are the ones who do a little bit better, but the rest, it's even. Yeah? So Jimmy, I challenge this,
the
and
other
I've
one
said
is,
enough.
The third one, Jimmy, was normalization of liver function, which you don't achieve very quickly in many patients, and enhances toxicity. So that is a very big factor.
Evrard, Geneva, Switzerland. I'm not a radio-oncologist, I'm an oncologist. But I was a bit surprised by what was said just before, and especially for the young one, I would like to make a comment. Both European and American are wrong. Sorry. Why? Because simply we are basing our judgment on old results made with old radiation therapy. Just to remember, at that time, at least some American studies, and I don't remember exactly ESPAC, but it was also, I mean, it was 20 gray for 2 weeks, then 2 weeks off, and then 20 gray again. And maybe sometime a third 20 gray 2 weeks later, which is a completely obsolete radiation therapy. The big problem with radiation therapy is we always speak about radiation therapy, but it's like chemotherapy, you have new drugs. When you look at chemotherapy, you look at new drugs. When you look at radiation therapy, you just say it's radiation therapy, nothing else. Yeah. But actually, no, we don't do the radiation therapy of 20 years ago. So actually, and it's a real problem because it takes so long to get results that by the time we get the results with radiation therapy, the radiation therapy has progressed. So anyway, I wouldn't say it's useful or it's, but we have to modulate our judgment because for in most of the subjects with radiation therapy, we're always ahead of the studies and the results. And so we have to really make a balance in our judgment.
Oh no, before Professor Buchler comes up, I really want to answer your question. 5-FU is at least 60 years old, and what a wonderful drug it is in pancreas cancer. Number two, the RTOG trial, undertaken in the United States with a huge amount of quality assurance and control of 538 patients, produced a median survival in both arms of 18 months. SPAC1, CONCO1, SPAC3, and wait for SPAC4, have median survivals in excess of 24 months. There's 6 months well off, 8 months well off what is achieved with 5-FU monotherapy and gemcitabine monotherapy. So, you know, please don't keep telling us we need better radiotherapy.
Maybe we also need better surgery. Huh?
Yes, you got it.
No, I think if we compare medical oncology, surgery, and radiotherapy, I think we should be fair. It is to be compared. And if you say radiotherapy is always better, then we know. I can't deal with this saying. I see radiotherapy every day, and you also. So do you see radiotherapy in pancreatic cancer working well? I mean, I know that data that have been published are outdated now. I agree with that. But this is also true for chemotherapy and surgery. We can always say, yes, now we are much better than we were. But this is not fair. I think We should compare what we have, and at this moment, radiotherapy does not look very well in pancreatic cancer. Maybe it will be better.
It's less toxic. I agree with you, but I would say in your judgment we have to be a bit more careful because we always are based on tolerance of radiation therapy, much more than the chemotherapy and research.
But what is also an issue, of course, is that with chemotherapy you don't get 100% response either. But it's usually better tolerated than the combination with radiotherapy. So that's also something we have to take into account, I think.
So next question, surgical question.
My name is Stefan Stettner, I'm from Innsbruck, I'm a surgeon. So what we see here, the discussion we had the same 10 years ago for correct liver mets. I think it was the same, so we started. So the same questions now for me come up. So first of all, how shall we measure response? And I will ask the same question after the next session, I guess. So that's one thing you mentioned. You mentioned PET-CT and CA99 levels. Second thing is, do you think this contributes to more morbidity, surgical morbidity? That's a question to you. And the third question is there still a role for intraoperative radiation therapy? Because we have some patients, I call them patient at risk, especially the left-sided at the back, where we might be very close. So is there still a role for intraoperative radiation therapy? Thank you.
Okay, if I may start, and also in answer to Werner Hartwig's comments. I mean, first of all, I don't think we increase mobility, but that's something up to trials. What I think is, of course, you can have a lot of arguments pro and con in both ways, but if we don't try it, we don't know it. And we've seen in gastric cancer, perioperative neoadjuvant treatment works. So, and in colorectal cancer, in the initially non-resectable, now has become standard, even if there were concerns. So I think it's manageable, and we have to do that, and we'll have to try it. My plea is to do it in a framework of a controlled trial, and not just do it, because this, I think, is dangerous, because we're doing something we don't know whether it's efficacious, and I consider that as non-ethical. If you have a protocol, we discuss that, the surgeon and the oncologist discusses this with the patient, it's a totally different situation as if you do it because we do it in our institution, and we have no idea whether it's efficacious. The question is response. I don't think we can really rely on conventional response, because we've seen even patients who have a good response and still do not improve overall or progression-free survival. We need better parameters, but this is a unique chance. You treat a patient and you can not only look at the CT scan, you can look at the tumor, and you can look at what's left. And you can see the outcome and how that correlates with outcome. And this, I think, molecular analysis of the tumor, then looking at what is a responder, non-responder profile, and whether a regression corresponds to disease-free survival in this setting. We haven't got enough data yet, and I think this is something we also have to acquire in these trials to move forward and to really know who is benefiting, because I'm absolutely sure not all patients will benefit from neoadjuvant treatment, but we will definitely find a subgroup who does with pancreatic cancer, and we should find out which it is.
The second part of the question was about intraoperative radiotherapy. There is a lot of, or there is some data about intraoperative therapy, but they are only in prospective small series. We used to use them, or we use them in Heidelberg, or when I have been in Heidelberg, use them for the recurrences or for the really initially non-resectable, to improve the local control of the retroperitoneum, where you have problems to dissect the celiac trunk or the SMA. That may help, but data is very scarce. And then you have to think about what is the real thing for the overall survival, for the outcome. Is it the local control, or is it more or less the systemic spread, the early metastasis to the liver? And I think this is still an open question. Yeah.
The NIH did a randomized trial in the 1980s of intraoperative radiotherapy. So it was sponsored by the National Cancer Institute, and they stopped the trial because it caused toxicity and didn't have a benefit.
I would like to thank especially Karen for her very critical statement regarding radiotherapy. I'm a medical oncologist, and I agree with Professor Büchler as well that what I have seen until now for preoperative chemoradiation really does not convince me. The question is, before we start to sing the requiem for chemoradiation, shouldn't we find perhaps or investigate more the question how we can integrate modern radiotherapy techniques into efficient systemic chemotherapy. And we had a very interesting talk, study just discussed in our EORTC meeting for rectal cancer, where our colleagues, they did 5x5 gray radiotherapy and then started immediately after that with FOLFOX and rectal cancer. And that seems to be quite a successful approach. This avoids the weeks we have in classic chemoradiation where you can't give effective chemotherapy. And if we do think about something like this, 5x5 radiotherapy, our short radiotherapy schedule followed by FOLFIRINOX, do you think this is feasible? Do you have any experience with this?
Actually, that is what is currently happening. We move completely away from these long courses of radiotherapy with low doses of chemotherapy and then 5 to 6 weeks before surgery. All the new phase 2 trials all use a very short course of radiotherapy, usually 10 days with a higher dose per fraction, and integrated with full dose of chemo before and during the interval to surgery. So I fully agree with you that that is the way to go. But so patients should be into trials, because otherwise we will never know.
Certainly. So this is, I think, what the SPAC trials, what, I mean, you have this nice trial about the neoadjuvant chemoradiation. I think, to my knowledge, this does not have this intensive chemotherapy and doesn't have a short course radiotherapy. So perhaps this is something, a way to go in the future. Thank you.
Just very short, sexy question for that. Professor Hasselmans, what would be the shortest radiation therapy with the highest fractionation dose you would administer for 3D conformal? 10 times by 300 or 15 by 240?
The way we do stereotactic body radiotherapy is that we have a lot of dose constraints for all organs at risk, and we have different treatment schedules, 1 fraction, 3 fractions, or 5 fractions, and depending on the dose constraints, we go for 1, 3, or 5, and we do it every other day. There is some evidence from the literature that if you can go for 1 big fraction, only 1, that you have much more endothelial cell damage and much more pro-inflammation, which could be beneficial compared to a more fractionated schedule.
But for conformal, not for SBRT?
That's for conformal, most data only use 10 fractions, and 10 fractions of 3 gray is the most common.
Okay, thank you.
Just a comment on SPAC 5. Anna? Just a comment on SPAC 5 and the radiotherapy used there. That was scientifically based. It was based on a very, very, very recent randomized phase 2 trial published in Lancet Oncology, and a trial called SCALLOP 2, which showed that chemoradiotherapy with capecitabine in the fractions used was superior to gemcitabine-based chemoradiotherapy, producing both increased survival and reduced toxicity. Now that is scientifically based. It's not just been made up. Could I ask Jimmy a question, an important question? And then we'll come on to you. And that is around the Ipmn. You mentioned in one of your talks that a lot of Ipmns give rise to pancreatic cancer, and you said that survival from Ipmn-derived pancreatic cancer was better than non-Ipmn-derived pancreatic ductal adenocarcinoma. Now, both are regarded as very similar adenocarcinomas, and my question really is a simple one. Is this difference in survival corrected for stage and grade? Or is it just that Ipmn cancers present maybe sooner?
I think the best data we have, or that at least I could find, was the one I showed you, that for stage control, when you look at the early stages, the Ipmn cancer, the T1s, the N0, they are doing better than the pancreatic ductal cell carcinoma for T1, T2, and 0. But when they are more progressed, they're exactly the same. So you don't have to miss these early stages, otherwise it's exactly the same. So the game is over for these patients too,
so it's good to take them out early.
Yes, I think so. you would like to get your own one if you have one taken out early and maybe before it progressed to cancer. But still, it's not like a colonoscopy and it's more difficult. I agree.
Hello, my name is Athanasios Stampakis, coming from Basel. I have a question for Professor Hartwig. You spoke about the parenchyma preserving operations, about Ipmn. Do we have any data or your personal data about recurrence rates after performing a parenchyma preserving operation for Ipmn?
At least we have them from Heidelberg, not yet, I think, or I guess that the colleagues that are still there are getting for this data. We have them from the Japanese, from Japanese studies, that there is still the possibility that the Ipmn recurs in the other parts of the pancreas, that's for sure, because there is that genetic thing that you tend to develop the Ipmns moreover at various sites of the pancreas. But you don't know yet. The ones that recur at the resection margin, that are probably not the frequent ones. And it's all about 3–5% in 5 to 10 years where you have the recurrence. So I think that's almost the same like in colon adenomas. You know that they can recur. You have to follow up them on a regular basis, and then you are quite safe. But you know at least what the predominance or the risk of the patient is, or at least you may have some more information about it.
Thank you.
So thank you for your attention. Thank you also speakers for discussion and for presentation. And I would like to close this session.